Honorable Minister of Health of the Republic of South Africa, Honorable Ministers and esteemed participants, I'm honored to speak at this year's International Maternal and Newborn Health Conference over this video, although I would have loved to be there with you in person. In the past 2 decades, Ethiopia has reduced maternal mortality rates by over 70%, as shown in the newly released report on maternal days. This success is a testament to the effectiveness of the different innovative policies, such as the Health Extension Program and investments to expand skilled birth attendance. However, despite this achievement, significant number of mothers and newborns still die from preventable causes. This is further worsened by the challenge of more than 3 years of the COVID-19 pandemic, conflicts, climate disasters, and economic difficulties. To meet SDG targets and reduce mortality, we need new innovations and approaches. The first is innovations in measurement. Strong data and information systems are crucial for measuring progress and holding ourselves accountable. We need innovation around measurement of public confidence on our healthcare, perspectives of women on providers' competence, and experience of care. Public confidence in the system facilitates uptake of needed care and adherence to treatment, and it promotes accountability. One good example for Ethiopia is our community scorecard, a citizen feedback mechanism to promote accountability and efficiency at primary healthcare level. We also need innovations in health financing, particularly to increase domestic resource mobilization and implement provider payment mechanisms like capitation. In Ethiopia, we're about to sign a family planning commodity co-financing compact with our donors, where the government will contribute increasing percentage of resources for family planning commodity. This initiative increases domestic resources and improves aid resource alignment. Another innovation is the use of health system redesign that enables women and their neonates access definitive management to complications of labor and delivery within 30 minutes. We're conducting feasibility.
My name is Unita Nyasita, working with the Ministry of Health, Migori, Kenya, as a CHW, being supported by Luala Community Alliance. In my village, we do household visitation. In the household visitation, we do register the members in the household. We also do follow-ups for mothers, maternal mothers. At the maternal mothers, we give health talk, especially on first trimester mothers, pregnant mothers. We do follow up them. We refer them for the first ANC up to delivery, which is the 4th ANC. With the mothers, we work very close with them. We work in the family, we are very friendly, and work as a team. As SHWs, the digital work has made our work to be very effective because we can only click the phone and then we see all the indicators. Now from the indicators, we can do follow-ups, more so on current pregnancy, newborns, children not fully immunized, defaulter tracing, has made the work to be very effective and very easy. Maternal and the newborn care is the heart of the work of a CHW. Before we came CHWs, there were many maternal deaths. The women were giving birth at home and their children were ending up dying at that period of birth. Because of that, it came to our realization that there was something missing. We came in as a team to support our villages, to support our mothers, so that they could know the importance of hospital delivery than home delivery. We as the CHWs, we were trained on CHW advocacy training. The training of advocacy has made us also to feel that we can be recognized. We can also hear some views from other CHWs around the world. We can see from Zoom meeting, conference calls. Here we sit together and discuss issues pertaining CHWs. So the training of advocacy has made us to have a change. We want to work for a change in order for the CHWs to be reconsidered like any other departmentals or any other sector of work. Because whatever we are doing on the primary level is very important to our people. So we need to be recognized. Lastly, professionalization has made us better CHWs than ever before. In that, we've been trained, we've been supervised, we've been given stipends, and we've been also given a mode of data that contains all the households with clients and every indicator. When you equip the CHWs, the lives of the mothers and their newborns will be safe. We have less maternal deaths, we have less ANC deaths, we also have less defaulters due to professionalization. Thank you.
Ladies, we need to do, and gentlemen, we need to do better than that, for our CHWs. Please, we need to do better than that. Do we have any CHWs in this room today? Anyone? Any CHW? Did I miss a hand anywhere? But we know them, right? Yes, so another round of applause. UNITA, we appreciate you. We appreciate you. Now, this is a very good crowd for a Thursday morning, 8 a.m., after being in the conference for a couple of days. So really good to see you. Thank you for being here. And welcome to the 6th plenary at the International Maternal Newborn Health Conference 2023. Today is our last official day, so thank you for staying put and for being here. My name is Mercy Juma, and I will be your moderator for this plenary and for the closing plenary, the 7th one. So just giving you a heads up that we are meeting here again at 4 p.m. Now, this session is a very, very exciting session. Not like the other plenaries that you have been, seeing plenary 1 to 5. Here, we are going to talk about new things, new ideas, innovations, what our dream world looks like for the people that have brought here to this conference. So we're talking about the mothers, the women, and the children. What does the dream world looks like? How do we overcome these challenges? How do we use, the innovations that we have and scale them up, the ones that are affordable to reach everyone, to make the health and well-being of women and children better? Now, let's close our eyes for just 3 minutes. Everybody, close your eyes. And imagine a world where no woman dies when bringing life to this earth. Imagine a world where in obstetric care for small and sick newborns is available even in the most basic, most rural, most remote health facility. How does that world look like? Open your eyes, somebody shout. How does that world look like? Beautiful, right? And I wish I could go around and just listen to all of you and what kind of world you are imagining for our women and children. And for the next 1 hour, that's what we are going to do here, to go to this dream world. I know we all have our dream worlds for this group of people, but for now, allow us to go into a world as imagined by Tafazo Meki, Executive Director of SALT Africa. Ladies and gentlemen, a round of applause for Tafazo.
I stand before you today with mixed emotions, both sadness and happiness. We are gathered here for something that is very serious. And let me just say that this is not another pity party for women. What we need to realize is that this is a woman, it's not a woman issue, it's a human issue. You may be wondering why, but hear my story. A real-life story of the importance of psychological inclusion as a priority throughout the maternal journey. To the world, I'm a mother of 3. But I'll ask you this. Can you tell that I've walked the path of miscarriage? Can you tell that I've walked the path of infertility, that I was constantly questioned why I continued to give birth to the girl child, until recently when I gave birth to a boy. But I'm being asked to have another baby so that I balance out the equation. Can you tell that I have walked the path of postnatal depression? A pregnancy journey where my mental health was never considered, where my emotions were a wreck, but I could not speak out. Can you tell that I spent sleepless nights, lonely nights, taking me to a place where I questioned my ability to be a good mother? Can I see, by a show of hands, who in here is not born of a woman? Your guess is as good as mine. But here we are today. You look at me as change makers, and you say, wow, she is a strong woman. But am I? Really? What defines strength? But imagine a world where every woman is asked intentionally throughout the perinatal journey, are you okay? Imagine how something as simple as psychological intervention, as maternal mental health inclusion throughout the maternal journey can reduce mortality, infanticide, and most importantly to a lot of you, the maternal bill on world economies. I hope that today, or what has been happening since the 8th, was not just another gathering of great minds, knowledge sharing, with great ideas that will simply fizzle away, but that we come out of this conference with real action to reduce maternal deaths and stillborns. This is not just an imagination. This is real. It can be done. It is being done. Through this journey that I've briefly walked with you on, I gave birth to this beautiful baby. Someone always listens to you in Africa, Salt Africa. And this baby is not for my family. It's for the African continent. It's for the world. Person-centered, community-led, with the heart of maternal mental health. These solutions lie amongst the communities in which we live in. The plight of LMICs cannot go unmentioned. Common perinatal mental disorders are the second leading cause of complications during pregnancy and childbirth. Perinatal depression is the second leading cause of the health burden in women. And unfortunately, in LMICs, we have not really measured the accurate stats, but it is approximated that 1 in 5 women has a common perinatal disorder. I am no longer silent. I am using my voice to speak out, to make a change. And a piece of me heals each time I touch the lives of these women. I challenge you today. What action are you going to take? Thank you.
A world where a woman's needs are the center of her care. Thank you so much, Tafadzo Meki. And now on stage, please welcome Jeff Stringer, Division Director at the University of North Carolina. And Jeff is taking us to a world where the diagnostic power of obstetric ultrasound is available to all mothers everywhere. Welcome, Jeff.
Good morning, everyone. I guess I have to advance my own slides. Here's a picture that should be familiar to pretty much everyone in this room. This provider, who I'll call Mrs. Banda, is an experienced and clinically competent midwife working in rural Malawi. And on the table in front of her, you'll see many of the traditional tools of antenatal care. So she has a wheel, in this case a gigantic wheel, that she'll use to determine the patient's gestational age and assign her due date. She has a tape measure for assessing fetal growth, a Plenary stethoscope for listening to the fetal heart tones, and of course, her own hands with which she'll perform the traditional palpations of midwifery. All well and good in most cases. But what if this particular patient does not know her or doesn't remember her last menstrual period, or maybe she has irregular menses? How then will Mrs. Banda assess her gestational age? Or what if this patient has a complication of pregnancy, maybe something common like twin gestation? A blessing, sure, but also a complication that requires specialist care. Maybe she has a more serious complication like placenta previa, where the placenta is covering the opening to the uterus, and a condition that is attended by huge risk of bleeding later in pregnancy. These are diagnoses that are best made by something that is, in fact, missing from this picture. And what is that? Ultrasound, right? The ultrasound is the linchpin tool for obstetrical care providers. It's like a stethoscope to us. And we've already decided or established that Mrs. Banda here is a competent clinician. Imagine how much better the care that she's able to provide would be if she had at her fingertips in this rural setting the power of obstetric ultrasound. I'll take it a little bit farther, and in concert with the theme of this session. Imagine a world where every Mrs. Banda had an ultrasound in their pocket. Well, you don't have to imagine that world. That world is here right now. These little devices, like the one that I have in my hand right now, I bought this one on Alibaba off the internet, are being manufactured by the millions now. They're cheap, they're getting cheaper, they're battery powered, and they can transmit their images from the probe to some smart device, either your phone or a tablet, something like that. Now, if you don't know how to use this, if you don't know how to navigate the probe to the correct fetal structure, you don't know how to interpret the image that you see on your phone, then it's not going to be of much use to you, correct? Well, not so fast. There's another innovation that we've been hearing a lot about in the news recently, which is artificial intelligence, or AI, right? Specifically a kind of AI that will allow us to jump over this obstacle of needing the sonographers to find the correct structure. Computer vision is able to interpret medical images more accurately than human beings in a lot of cases. And we know this from ophthalmology, from pathology, from lung ultrasound, breast screening, and now obstetrical ultrasound. In fact, my group that works at the University of North Carolina and also in Zambia, and many others, some of whom, the University of Oxford, some of others who are actually in this room, have been working to develop AI algorithms that can take a series of blindly obtained ultrasound sweeps. So we do 3 in the craniocaudal direction, 3 up and down like this, 3 crossways like this, and make all manner of diagnoses. We can tell you the gestational age of a fetus more accurately than a professional sonologist using a $50,000 ultrasound machine. We can diagnose twin gestation. We can diagnose fetal presentation. Is the baby head down or head up? Where's the placenta? How much fluid is in the uterus? The possibilities really are endless. These devices are here now. You can find them in the exhibition hall. You can also find them deployed all over the place. For instance, at this site in rural Kenya, where this midwife is using one of the butterfly devices. Imagine the improvement in care that we can deliver in a setting like this if we have the diagnostic capacity of one of these little devices in every setting like this. These devices will democratize the availability of obstetric ultrasound. No longer the purview of just a doctor in a hospital, but now a primary caregiver in a rural facility, even, and imagine this, a community health worker visiting a patient in her home. So over the next months, not years, but months, you will begin to see devices like this, devices like that, empowered with AI, appearing all over the place. They will improve our capacity to make important diagnoses. And as an obstetrician who's been working in global health my entire career, I could not be more happy and more enthusiastic about the future of primary health care, primary health obstetrics, than I am right now with one of these in my pocket. Thank you very much.
Now, ladies and gentlemen, please, if you have any questions for any of our TED speakers, please feel free to use the Menti app. Send your question there, type your question there, and it would be lovely if you told us who among everybody who will come on stage you would love to answer these questions. And after each one of them gets on stage, we will put them to task. So please send all your questions, all your clarifications. But now, coming on stage is Bilotol and Pfizer to talk about the microbiome and organisms within our system and how they can be used to improve care. Bilo and Pfizer, you're welcome.
Pfizer, imagine a world where unlocking the power of microbes through the microbiome can improve pregnancy outcome for both the mother and their babies.
Below, that would be amazing. As you already know, the microbiome is like a forest living inside of us, composed of many different species of microbes. These range from between 300 to 500 types of bacteria, viruses, fungi, and even protists. Indeed, our microbiome is made of over 100 trillion microbes.
Wow! This means that there are much more microorganisms in our body than there are human beings on the planet.
Did you ever imagine that we have such a huge population of tiny microbes living inside of us? But why do we have so many microbes living inside of us? What do they do?
We have discovered that these microbes are crucial to our health system, both mental and physical. For example, they can help us digest food, provide us with nutrients, help us fight pathogenic bacteria, and support the immune system.
Imbalances in this tiny universe can result in adverse outcomes in pregnancy, such as preeclampsia, gestational diabetes, and even postpartum depression.
However, a healthy gut microbiome with the good microbes in pregnant women can, for example, help optimize the absorption of important nutrients, such as important vitamins, important minerals, which are necessary for fetal growth and development.
So, microbes don't always hurt us. They can help us too, in so many different ways. That's awesome.
Yes, and by studying more the microbiome of pregnant women, we can know how to ensure a healthier and happy pregnancy.
Agreed. In a study that we did back in my hometown in Karachi, Pakistan, among breastfeeding women whose stool showed an abundance of a certain type of microbe known as the bifidobacterium, their babies gained an average daily weight of 3 grams greater compared to babies of moms whose stool did not have bifidobacterium. At 6 months of age, Babies whose moms had bifidobacterium in their stool were much healthier.
That's why we are diving into the microscopic world of the mighty microbes and try to understand and to discover how simple medicine, such as probiotics, can improve pregnancy outcome.
The use of probiotics can be a safe strategy during pregnancy to improve healthier babies.
Probiotics are food or supplements that contains live microorganisms. It can be in powder form to be mixed with juice or porridge, and it can be in capsule form too.
Imagine if taking something as simple as a probiotic every day could result in healthier pregnancy outcomes. I do feel like the microbiome is the unsung superhero of pregnancy, working tirelessly behind the scenes, helping expecting moms and growing babies.
That's totally true. And maintaining a healthy microbiome during pregnancy is essential for the health of both the mother and the developing fetus. So, remember, microbes don't always hurt us. They can help us too.
So let's embrace the power. Let's celebrate the power of the mighty microbiome and embrace the fascinating science that could revolutionize prenatal care. Thank you.
Thank you very much, Bilo and Pfizer. And now to a world where new drugs can dramatically change the way women experience pregnancy. Kathy Culver from the Stellenbosch University, you're welcome. A round of applause, ladies and gentlemen.
Morning, everyone. So today I want to talk about drugs in pregnancy. Drugs. Now, I don't mean illegal drugs. I'm talking about drugs that we use to treat and prevent conditions of pregnancy. Now, just looking at you, I can already see the facial expressions. Some of you are feeling a little bit uncomfortable in your chairs. And we have to unpack that, and we have to say, why do we feel a little bit uncomfortable? I think it really goes back to this. It goes back to the thalidomide and DES disasters. As you can see in this advert, these drugs were advertised as being safe in pregnancy, a drug to treat miscarriage, preterm birth, and even morning sickness, a wonder drug, until malformed babies were born. The world was outraged, and rightly so. Pregnant women should be protected. Policies needed to be put in place. Drugs are dangerous. The best thing to do is to exclude women from clinical trials. All very well, but what was the effect? Now, 80% of pregnant women are taking drugs that haven't been studied adequately in pregnancy. Women are often stopping drugs because they're scared and inadvertently causing more harm. In a register of clinical trials, it's pretty scary when you look at the data on pregnancy. 1 in 3,000 trials was looking at pregnancy complications and drugs to treat them. And only 3 new drugs had been developed specifically for pregnancy. If you think back to the COVID pandemic in the beginning, we all wanted to protect women. We're going to protect them, we're not going to give them vaccines. But what should we have been doing? We should have actually been giving them the vaccine to protect them. Have a look at this graph over here. What you can see there is the incidence of something like preeclampsia compared to inflammatory bowel disease. Preeclampsia is more common than inflammatory bowel disease. But look at the vast disparity in the number of trials. Our policy of trying to protect women by excluding them from research is not working. We need to do better. And how can we do better? We can do better by including pregnant women in drug trials. We need to stop thinking of pregnant women as being vulnerable. We need to think of pregnant women as being scientifically complex. We need to adjust for the baseline rate of malformations and not immediately blame it on that drug. We need to encourage people to do drug research, and we need to actively fund this research. Otherwise, it's not going to happen. So you're probably thinking, why is she standing there talking to us today? So I'm standing here talking to you today because I conduct drug trials in pregnancy. For the past 10 years, I've been working with a team in Melbourne University, and we've been running these trials here in Cape Town at Stellenbosch University. My area of interest is preeclampsia, and we've been studying drugs to see if we can find something that can keep women diagnosed with preterm preeclampsia pregnant for longer. The reason we want to do it is to decrease the burden of prematurity. Our first trial was disappointing. Esomeprazole did not work. But what we did find was that pregnant women wanted to be included in research. Specifically, pregnant women with preterm preeclampsia wanted to be included in drug trials. So we carried on. We did our second trial. And in our second trial, we found women who took metformin. They stayed pregnant for a week longer. Exciting, but still not enough. So now we're moving to our third trial, and we're randomizing in this trial already. And what we're aiming to do is see if metformin can keep these women pregnant for longer, but also have beneficial neonatal effects. Excitingly, others have been inspired to join us. Now we have researchers from Sweden and hopefully the Netherlands too, who are going to be joining us to work out if metformin can possibly prolong pregnancy in preterm preeclampsia. Others are joining. The Accelerating Innovations for Mothers program is finding solutions. Private companies like Comanche are designing novel therapeutics for preeclampsia, but this is still not enough. People find drug trials scary. We need to educate them that it's more scary and more dangerous not to be doing these trials. Imagine a world where we had drugs to treat the most common conditions affecting pregnant women and their newborns. I believe this world is possible if we work together. Thank you.
Much, Kathy. And now our last speaker is Sathi Rajashekharan, Executive Director, Jacaranda, talking about data and how it can be used to target services depending on demographics and geography.
40-something years ago, I was born in a government hospital in Zambia. The doctors told my mum that I would die if I didn't get a blood transfusion. Eventually, I was fine. All I needed was a little bit of time under a phototherapy lamp. But it wasn't until years later that my mum found out that I had severe jaundice. And I remember her telling me how helpless, terrified, and alone she felt without the information to support her. Now I work for an organization called Jacaranda Health, where we work with government hospitals to improve the quality of care for mothers and babies. We know that in Kenya, where Jacaranda is headquartered, a lack of information leads to delays in care seeking, which results in 30% of the maternal deaths in the country. I think of a mother like Beth, a young Kenyan woman who lives in rural Kenya in Kakamega. Beth was late into her first trimester at night, and she noticed spotting. She thought it was normal. By the morning, it had turned into heavy bleeding. Everyone in this room knows that this kind of lack of information for someone like Beth and the results that can come from that. A lack of information. We live in the information age. I want to fill in the blanks on Beth's story because you see, she didn't have a lack of information. Beth has a phone, and she had been receiving text messages right from the start of her pregnancy, explaining everything about her pregnancy, including danger signs. When her husband found her bleeding in the morning, he texted into the service and said, "My wife is bleeding. What should I do?" Machine learning picked up his message from 5,000 other messages that day and put it up as an alert. A help desk agent called Beth's husband and said she needs to get to care immediately. The text message helped Beth seek care at the right time and right place within hours and not days, as is often the case. Unfortunately, Beth lost the baby, but she said she felt supported throughout this entire process. I'm proud to say that over 2 million mothers across Kenya and Eswatini, and soon Ghana, have used this service called Prompts, which gives them information via text message through their phones so that they can seek care at the right time in the right place. But you see, this isn't the only thing that happened in Beth's story. When she got to the facility, she was told that there weren't the right providers there to be able to support her, and so she had to take a taxi to another facility. When she got to that facility, there was a delay because there wasn't the right kind of blood to be able to support her. Imagine a world where Beth's experience of care informed where every shilling, every cent, every rand gets spent in the health system, improving the services for mothers like Beth. Beth gets to the facility where there are the right providers because a coordinator knows exactly where to train providers, where to place them, and when to do it. She gets to a facility with the right type of blood for her because there's a database sharing exactly where the different kinds of blood is. And her experience of care and respectful care is a data point that's an example for other facilities in the neighboring area. Continuous feedback from the user informing the services that they receive. The exciting part is that this data already exists. The dashboard behind me is being used by over 1,300 facilities in 20 Kenyan county governments. Health system managers are using this information from mothers to be able to make decisions on where to allocate resources and improve services. Now mothers don't need to feel helpless, terrified, and alone like my mother felt all those years ago. Mothers are empowered like Beth, who's expecting her second child. Imagine a world where millions more journeys like Beth's inform and improve and shape the services that those mothers receive and that save lives. Thank you.
Ooh, what a world. Okay, let's come back to our present world with all the challenges, everything we've been talking about the last 3 days, and we are finalizing today and tomorrow. If you just compare what we've been talking about and what has been presented here, are you optimistic? Are you feeling like something can be done and you are ready to do this in your capacity as an individual, your organization, your community? Are you optimistic? Can I get an ahoo? Thank you. Now, shortly, I will call all these speakers back on stage for us to have a bit of a chit-chat, and thank you so much for your questions. They've been coming in hot and furious. Probably we should do them mainly again, so send in your questions. If we do not get to address all of them here, we will make sure this team reaches out. Hopefully you can also leave your name and your organization and how we can contact you, and they will get back to you. Now, let me tell you a story. Sethe, FYI, my hometown is Kakamega. Yes, that's Western Kenya. And ladies and gentlemen, I am a child of a midwife. My mom is 72 years old. She's been a midwife for more than 45 years. And we talk a lot. She tells me, about what she does. I have had people knocking at our door because where her facility is, we live right behind, and we have had people come and knock at 12 a.m., at 1 a.m., and one of us has to escort her to go to the clinic. A woman has come, she's in labor, she needs to do the needful. A woman has come back with her newborn baby, she needs to take care of it. So I'm aware of the night runs and her spending lots of time in this facility. Now, when I was coming here, I had a really long call with my mom, and she told me, you go and talk, go and, do these talks. And I have been doing this for a couple of years. And she said something that really tugged my heart. She is set to retire because she's 72. But she said she is retiring when the same things that used to kill mothers during childbirth and newborn babies and children 30, 20 years ago are still happening today. The same things. We need to talk. And this morning, I called her again, we did a WhatsApp call, and I told her about this Imagine a World Where, and I asked her, Mom, what is your dream world? And you know what she told me? She hopes that by the time her time is done here, that we will be talking about different things. That even if she doesn't get to see the world where all these innovations are taking place and all that, that it is going to pass. And I really hope it gets to pass when she's alive and she can see this. I want her to live more years, but I don't want us to keep her for so long as she waits to see this. So we need to act, and that's why we are here. So there are people who've been seeing this for years. It's just not right that we come and talk about the same things. And thank you so much for this innovation and ideas. And you know what the beauty about all this is? It can be scaled up. They are available. We can take them to the communities. Together we can do this. Ladies and gentlemen, can I have my panel back on stage? Please come. Sit wherever you feel comfortable. And thank you for the questions. Those are the questions we are going to address now. I'll wait for everybody to take a seat. I hope nobody is going to take my favorite spot. Okay, go on. I'll give you first priority. No, go on. Which one? I'll give you first priority. I'll sit with the gentleman. All right. And there's one person here who was not on the speaker list, a really amazing gentleman, Ressa.
With a long last name.
With the longest last name, which means?
May God take care of you.
May God take care of me. Please, can you tell them your last name?
Hi, everyone. My name is Rassa Izad Negadar.
Yeah, yes. May God take care of you, and all of us here. So thank you so much, Ressa, for being here. And my first question will go to you. So Ressa is the director of the Maternal Newborn Child Health Discovery and Tools team at the Bill and Melinda Gates Foundation. Welcome to the panel, and thank you so much for sparing your morning to be with us. Now, we have heard of incredible innovations, incredible ideas presented here. And, how does it look like to scale this up, to take all this from an idea to something that is actually being utilized and realized in our communities? How do we scale these ideas up?
Thank you, Mercy. I think it's a great question, and thanks to all of the speakers today for the ideas that they have shared. I think what makes me excited to think through these not just being ideas and having a real likelihood of getting to scale and impacting the lives of women, of mothers, of their newborns, is that these aren't just ideas that came out of nowhere or ideas that came out of one person's mind and one person is trying to push. These are ones that are responsive to the needs of communities and to a better understanding of what truly happens on the ground. That takes data. All of the ideas that you've heard today, from the mental health, psychological inclusion, to Kathy's point about trials, to the ultrasound, it is fundamentally founded on having the right high-quality data on the ground, on the experiences of what women are living through, working through, what those challenges are. So the first thing that gives me confidence is ensuring that that data is rigorous, it's representative, and it's actionable. We know that context matters. None of these solutions are going to look the same everywhere that we work. It has to be uniquely adapted to the areas and to the lives of the women that we're taking care of. That only happens if the quality of the data is high. The second is to iterate, fail and iterate again. None of these are the first iteration of what the idea has been. It wasn't just a single piece that went forward. I'm sure you, just in the last one, there's many different versions of that software that have been written before the dashboard that you see in front of you. iterating ensures and is something that is true to science in all of the other fields, and yet some of the apprehension that Kathy shared prevents us from doing the same in maternal health. Makes us think we have one chance to get it right and that's it. And that's what we need to revisit and think about, because by iterating in context, you end up at a solution that is living, that is adaptive, that can respond to the needs as those change. And we are in the midst of change. Just over the past few days, we've learned about how rates of PPH will change with the Emotive launch. We've heard about C-section rates being high. All of these are an evolving system of care that's being provided for mothers. We need to iterate so that the technology and the solutions that we bring forward keep up with that change. And the last is to bring the community along. These are not solutions that are here to be made, and then once they're done and packaged, we go and think about, hey, community health workers, how do you feel about this? This needs to be something that policymakers, women, mothers, husbands, community members, policymakers, everybody that's in this room is engaged from the outset in identifying what those needs are so that we can address them. To me, each of these represent solutions that have gone through each of these stages, that are living and evolving, and that's what gives me confidence that they will reach scale, for they have to reach scale for it to have the impact we want it to.
Thank you very much. They have to reach scale. But you're talking about technology, you're talking about, scaling this up. That needs money, right? Jeff, what financial considerations should we be talking about to actualize what Rasa is talking about? What are the financial considerations? That's a question from somebody in the audience.
So if I understand it, the question, the question has to do with how much do these things cost and what will it take to actually really implement them and then put them in the pocket of every provider? Well, that's a good one. There are a lot of models that are being considered, and I'm not an expert on this, okay? I'm an evangelist for ultrasound, less so like a financier, okay? But there are a variety of different options, I think. It's going to require, especially as we get going, the input of the donors. The donors are going to have to step in and realize that this is a way to really substantially improve outcome, and by the devices themselves, by service contracts, that sort of thing. I think that's going to absolutely be necessary. But ultimately, government will have to step in and understand that this is an essential part of obstetrical care. It is like a blood pressure cuff. It's like being able to measure hemoglobin. It is essential, and I think that we need to socialize that. And I see my job as trying to convince the decision makers that this has real benefit for the outcomes of mothers and babies.
Thank you very much. And you talk about outcomes for mothers and babies. Tafazo, there's a question that we cannot leave without discussing. It's about mental health in women. And a member in the audience is asking, what are the local resources in low-income settings women can consider to fight postnatal depression?
I think our biggest sustainable and most inexpensive solution is us, the people. Support groups and just simply finding space to talk about it, to kickstart the conversation before we start thinking of donor funds and the bill, rather, without putting dollar signs to it. It's the people. Our human resource is our greatest resource.
We hold space for each other, right? Yes, we hold space for each other, create safe spaces for each other. There's so many things that come with pregnancy. I am a mother of two, so I have a bit of an idea what goes into this. Kathy, you're sitting next to Tafadzwa. Let's talk about preeclampsia. Are there new ways of understanding both the cause and progression of the disease that can guide the development of new innovations? That's the question for you from the audience.
Sorry, say that again, I didn't hear.
So, are there new ways of understanding both the cause and progression of preeclampsia that can guide the development of new innovations?
I mean, I think that's why I love preeclampsia, because it's probably one of the most challenging diseases that you can look at. We still don't actually even understand why certain women develop preeclampsia. Why do they get it once? Why don't they get it in the next pregnancy? There's so much information coming out. I think if you're reading the literature, sort of every week there's something new. There's a new idea. There's a new way of looking at it. So there's certainly things that are always coming up about preeclampsia. And I think all of these things need to be incorporated. Just thinking of metformin, you know, we don't even really know how it works. I mean, I'm saying we must try a drug, but I don't even know how it's working. And I'm trying to investigate that as well. So I think the whole thing is just incorporating all of this knowledge, putting it together, and continuously having an open mind, not being set necessarily on one drug or one mechanism of action or one pathophysiology for the disease. We need to continually better understand it so that we can better implement treatments.
And really look into drugs that can work for this, right?
Absolutely, yeah.
Now, in talking about drugs, Bill and Pfizer, somebody's asking, can there be too much of a good thing when you look at probiotics? Like, what is the risk of probiotics going wrong?
Well, yeah, I can take that. So probiotics are actually substances that are generally considered as safe during pregnancy. And I would say there is zero data to support that probiotics can harm at this point. However, we do know that an absence of data or evidence does not mean an absence of the effect, in this case, a side effect or a harmful effect. So yes, we have always learned in the innovation space that we need to face challenges and take big risks. And there are very carefully controlled, randomized controlled trials. Several of them are in phase 2, where we are testing these probiotics in terms of both their efficacy as well as the harms or the potential harms that they can produce. But the balance of effect and the lack of harm is actually more in favor of probiotics right now, based on a lot of observational data and some initial randomized control trials. So I would say too much of anything is probably a bad thing, but we need to find the populations and the women who need to be targeted for such type of interventions.
Yes, I agree with you. That's why we are doing many clinical trials to understand more the utility of the probiotics and the safety of the probiotics. But like Faiza said, now we don't have any data who show us that the probiotics are not safe. So that's why we, as we said, evidence-based medicine. All the sentence which we talked to you together today, it's like based on data. So we need to have more clinical trials on pregnant women, like we say soon.
Thank you. So many questions that I feel like we need to talk about. These are conversations I can have for a whole day, and I need to at least cover a bit of everything, so I will come to you, Sethi. Please forgive me if I don't address your questions. It's just for the interest of time. Sethi, are there ways that the communication tools that you have with mothers can be used for more precision public health approaches? Like, we don't have the resources to do everything, so how can these targeted interventions be better used based on our resources?
That is an awesome question. I will give an example for how it can be used and how it's being used in Eswatini right now. The ministry understood that they have under-immunized infants, especially post-COVID, and they understood the power of digital health, and they said, can you put mums on this platform to let us know whether their babies have been vaccinated? We cannot do campaigns everywhere. Tell us where we need to put our resources. So then we have mums using prompts, talking back and forth, telling us when their babies got vaccinated, and we find hotspots. And that's where the campaigns go. That is precision public health. When you get to 95% immunization, the strategies for the 5% are going to be wildly different than the strategies that got you to 95%. This is our quality of care conversation here at this conference, right? And that's how digital tools can help us. solving the problems we've been trying to solve before, but using these tools to augment and optimize.
Thank you, Sathi. I will find you in Kakamega.
Yes.
All right. Top of the hour. Our time is up. So I'll just pose one last question to Rasa. We have talked about technology. You've mentioned technology. And we are at the dawn of, the era of AI. Everybody's talking about AI and how it's going to change things. So what else is on the horizon for AI, based on what we're discussing here, and what other problems can it solve?
Yeah, there is a lot of talk of AI, that's for sure. I think it is one of the technologies that's expanding, but certainly there's a lot of progress being made across the board for technologies that impact all of the innovations we heard of today. More widespread genomics capabilities that helps us understand which strains of bacteria are the ones that we should care about. An understanding of preclinical pathways and etiology of disease that helps us understand what Kathy was talking about in terms of what drives preeclampsia. We have in the midst of us scientific progress that many fields are leveraging in order to advance diagnostics, prediction, prevention, therapeutics. That should belong to the maternal health community as well. It's onto us to leverage that and not be afraid of it, not to think of it as it's just the future, but think of it as the now, and how do we leverage it as the now to take it forward. I think AI has great promise. The large language learning models that we are seeing become useful and used across different settings has opportunities to help accelerate some of what Satya was just talking about in terms of looking at those spots, providing feedback, helping engage with women across many different languages. We saw some of that on display here yesterday as well. And yet there's also benefit in the prediction aspect. So what Jeff talked about in terms of the algorithm layer, what we talked about with many of you over the past few days in terms of how that can be improving through sensors, antepartum care, intrapartum care, and postpartum care. The stories we've heard in terms of women after a C-section where for that period of time everything is monitored and then the C-section is done and nothing else. These are low-hanging opportunities to address, and these are technologies that are becoming more and more widespread. Now in the traditional way of things we would say, okay, well these will benefit high-income settings, we'll wait 5 years from now to launch them, and yet we're really pushing to think of this when the data is coming from the areas you want to be serving from day one, then the products should be launched in those areas on day one, not waiting.
Thank you very much. And that, ladies and gentlemen, brings us to the end of this session. And I hope you leave here feeling really energized, really encouraged, and optimistic that there can be a better world for women and children. And I'm looking forward to the next conference. And I hope we can come here and now take stock and discuss how these ideas, these solutions, all this tech has made a change in our communities. We have the ideas, we have the innovations, we have the solutions. We have the goodwill, but we need more of the goodwill. But most important, we need each one of us to work in our own individual capacity to just make this world a better place for our women and our children, right? So thank you so much, and have a wonderful, wonderful rest of the day.